This lecture is about acute upper respiratory tract infections. Overprescribing in acute upper respiratory tract infection is a common mistake in healthcare. It's important to know that antibiotic resistance is driven by the total volume of antibiotics used, and is not merely driven by the use of broad-spectrum antibiotics in hospital, for example. Therefore, overprescribing in acute upper respiratory tract infection is a major driver of antibiotic resistance worldwide. Acute upper respiratory tract infection is composed of three clinical syndromes. Those are pharyngotonsillitis or sore throat, acute otitis media, and acute bacterial sinusitis, and we'll cover each of these in turn. Regarding sore throat, the definition is acute inflammation of the pharyngeal wall and tonsils. In terms of likely pathogens, up to 95% of sore throats are caused by respiratory viruses or the Epstein-Barr virus. 5 to 30% are caused by group A beta hemolytic streptococci. Even if sore throat is caused by beta hemolytic strep, the illness is self-limiting, and the primary reason for antibiotic therapy is to prevent post-streptococcal complications such as acute rheumatic fever and glomerulonephritis. When we see a patient with sore throat, the first thing we need to decide is whether this is of bacterial or viral origin. There are clinical features that can help differentiate these two possibilities. Bacterial sore throat is typically of acute onset, with a high temperature, predominantly occurs in teenagers and children, is associated with tender anterior cervical lymph nodes, and may occur in patients who've had previous rheumatic fever. Clinically, there may be pus on the tonsils, as in this picture. Viral sore throats are typically associated with rhinorrhea, a cough, conjunctivitis, sometimes diarrhea, typically occur in the older age group. This is a typical picture of an inflamed oropharynx in a patient with a viral sore throat. Some clinical scoring systems have been put together and formalized so that they can predict the need for antibiotics in sore throat. One such score is called the fever pain score and is freely available online. Use of fever pain score safely reduces the use of antibiotics in sore throat. This is an example of what it looks like online, and you merely fill this in and display the score, and you get appropriate advice on the use of antibiotics. Some tests can be useful in sore throat, such as CRP, procalcitonin, and a rapid streptococcal antigen test. When negative, all of these can be used to reduce antibiotic use without compromising patient care. If a sore throat is thought to be bacterial, these are the treatment options. Penicillin, orally for 10 days, or intramuscular benzathine penicillin as a single dose, and for patients that are penicillin allergic, azithromycin for 3 days is reasonable. Moving on to acute otitis media. The definition is acute inflammation of the middle ear, and the likely pathogens are Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. The clinical features are ear pain and decreased hearing, and you may see reddening and bulging of the tympanic membrane, which may be perforated and draining pus. In terms of tests and treatment, no tests are required. In terms of treatment, initially analgesics and decongestants are all that is required. Antibiotics may be needed if the patient is febrile or if the symptoms do not settle spontaneously within the first 48 hours. And if antibiotics are used, amoxicillin orally for 5 days or azithromycin orally in the penicillin allergic is a reasonable choice. Moving on to acute bacterial sinusitis. The definition is acute bacterial infection of the paranasal sinuses, And the likely pathogens, as for acute otitis media, are Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. The clinical features are this is often preceded by a viral upper respiratory tract infection and presents with fever, facial tenderness, dental tenderness, nasal discharge, nasal congestion, and anosmia. In terms of tests and treatment, usually no tests are required. Symptomatic treatment is often all that's required. Paracetamol, decongestants, and nasal steroids perform better than antibiotics. Antibiotics should only be prescribed if the following are present. Those are patients who've had symptoms that have lasted greater than 10 days, those that have a high fever and a purulent discharge, as well as those with facial pain, and a biphasic illness with sinusitis following a typical viral upper respiratory tract infection. Antibiotics that can be used are similar to acute otitis media, amoxicillin orally for 5 days, or azithromycin for 3 days. In summary, acute upper respiratory tract infections comprise 3 clinical syndromes. Sore throats are self-limiting and usually viral. Clinical scores can help determine which patients require antibiotics. Acute otitis media should be treated symptomatically in the first instance, and antibiotics should be reserved for prolonged or complicated infections. Acute bacterial sinusitis responds well to symptomatic treatment and nasal steroids. Antibiotics should also be reserved for prolonged and complicated cases.